Dear colleagues, I would like to present you my 9 months progress on my topic, translational key points between radiology, physical examination, and hand surgery. My name is Luca Hergár. I'm a resident doctor at the Department of Orthopedics at Semmelweis University. My vision is adequate diagnosis at the first doctor-patient interaction, and my mission is to evaluate the accuracy of diagnostic methods in hand surgery. I'm currently working on 3 topics in connection with diagnostic methods in hand surgery that I would like to show you in details now. My first project is investigating the diagnostic accuracy of magnetic resonance imaging for lesions around the wrist. What is important to know about the background of this project is that wrist soft tissue injuries are common pathologies. And now, the gold standard diagnostic tool is wrist arthroscopy. However, this is an invasive method with a risk of complication. Another alternative diagnostic method is the wrist MRI, but there is no consensus in the literature about its diagnostic accuracy. This is why the aim of our topic, or the aim of our project, is to determine the diagnostic accuracy for MRI and also find out the factors that might influence the diagnostic accuracy. We are currently now at the article writing phase of this project, as we have recently obtained the final results, and we plan to finish the manuscript next week. Our aim is to publish our study at the British Journal of Sports Medicine. Here you can see our PICO, and also our hypothesis. Our hypothesis is that the diagnostic accuracy of MRI is close to arthroscopy, and there are certain factors that we can identify what might decrease or increase the diagnostic accuracy of MRI. We have conducted a systematic search on the 22nd of October last year, and after the selection protocol, we found 38 eligible articles. Here you can see the forest plot showing the pooled sensitivity and specificity of the included articles. The calculated sensitivity was 75% and the specificity 85%. On this image, you can see the summary point of the included articles calculated by the sensitivity and the specificity of the included articles. You can see that sometimes the studies are quite far from this summary point. This shows that our sample is quite heterogeneous. In this table, I would like to present you the effects of different technical aspects of MRI on the results. You can see that the field strength of the MRI can have an impact on the results. We can determine that the minimum criteria for wrist MRI should be the 1.5 Tesla MRI machines. Low field MRIs are not reliable enough during the clinical practice, and although 3 Tesla MRIs can increase the diagnostic accuracy, but we need further studies to confirm that hypothesis. We found that the use of wrist coils can increase both the sensitivity and specificity with almost 10%. The use of 3D sequences increased mainly the sensitivity, while the fat saturation had a positive effect on the specificity. In this next table, you can see that we assessed the diagnostic accuracy for different types of ligamentous lesions, for triangular fibrocartilage complex injuries, scapholunate ligament injuries, and lunatic vertebral ligament injuries as well. We found that the best results were achieved in the case of TFCC central and peripheral tears, suggesting that if we ask a precise question, we might get better, more precise results. Also, for scapholunate and lunatic vertebral lesions, we found that the field strength of the MRI can have a really big importance, and if we have a clinical suspicion of this kind of lesions, we advise clinicians to use the 3 Tesla MRI machines. What we can see is that one of the strengths of our study is that beside the sensitivity and the specificity, we also investigated different factors that might be affecting these results. This is something what we haven't found in a previous meta-analysis. However, we are aware that our study has limitations as well, for example, the heterogeneity of the included studies and sometimes the data quality as well. All in all, we can say that MRI is a reliable preoperative diagnostic tool, but clinicians should be aware of the limiting conditions. We can conclude that the field strength has a big importance, and 1.5 Tesla MRI machines should be a minimum requirement for wrist MRIs. Also, we advise the application of wrist coils as it increases both the sensitivity and specificity in a clinically important way. In terms of clinical suspicions of ligamentous lesions, we found that the best results were achieved for TFCC central and peripheral lesions, and we advise clinicians to ask precise questions if they want to have precise results as well. In practice, we encourage the discussion between hand surgeons and radiologists, as we are certain that this would lead to better results, and also this would limit the number of only diagnostic wrist arthroscopies. Also, the standardized guideline for both MRI and wrist arthroscopy could decrease the uncertainty of the diagnosis, and we advise researchers to determine minimum criteria for these guidelines as well. My second project is about the correlation between two-point discrimination and electroneurography in carpal tunnel syndrome. During carpal tunnel syndrome, the median nerve is under compression, causing motor and sensory loss of function. Currently, the gold standard diagnostic tool is electromyography and electroneurography to assess the severity of this disease. During the physical examination, two-point discrimination is used to examine the sensory function of the hand. Based on the American Association for Surgery of the Hand guideline, we can determine 3 different categories for these two-point discrimination values: normal, moderate, and severe categories. The evaluation of the degree of severity of this disease is important for us to be able to choose the adequate therapy and also for follow-up. Our hypothesis was, for this project, is that there is a correlation between two-point discrimination and the electroneurographic values. And here, let me show you our results. Here you can see the correlation coefficient and also the confidence interval showing the relation between two-point discrimination and the different electroneurographic values. We found a significant low correlation between two-point discrimination and distal sensory latency, and also with severity of the disease. However, this correlation is not strong enough for the two-point discrimination to replace the ENG in clinical practice, but we still consider that this is a reliable tool for an orientation for the clinicians, and this is why we advise to use this examination technique as well. Our third project is about the investigation of the effects of different conditions on two-point discrimination values. Our hypothesis is that there are certain conditions, such as age, gender, pregnancy, or cortical function, that might have an effect on two-point discrimination values in the general population. We have conducted the systematic search on the 7th of December last year, and now we have finished the title and abstract selection, and we are at the full text selection phase. We hope to continue with this project very soon as well. Here you can see an overview about all of these 3 projects, and our aim is to complete these projects by the end of the summer. I would like to thank you for your kind attention with a quote from Antoine de Saint-Exupéry: "A goal without a plan is just a wish."
Thank you, Luca. Just from your third project, I would like to ask that if the patient has these conditions, that shifting the two-point discrimination, and what to do with it. So what if the patient has such conditions? Should we change the protocol of the two-point discrimination, or just leave with the conventional EMG, ENG?
Thank you for your question, Miki. I think there might be a change if we found that there are significant effects of these factors on the 2-point discrimination values, because what is quite known is that the age might be a risk factor for these longer 2-point discrimination values. And this would mean that if we are examining an older person, we might think that they have nerve damage, although this is just a normal thing that the 2-point discrimination values get higher as their age increases. So I think we have to take it into account when we find these results, and maybe be more flexible by the evaluation of 2-point discrimination values.
I would like to have another question, please. Did you have any information on arthro MRI and its accuracy? Because I haven't seen it on your list.
Yes, the reason why it's not there is because we try to exclude the invasive methods. This is also an invasive method, although of course not as invasive as the arthroscopy itself. In most studies, what I've read, the sensitivity and the specificity was a bit higher than without contrast material. And this is why we wanted to do this study, to find out, is there any way to increase the diagnostic accuracy without contrast material, because that way we could exclude the secondary effects from the contrast material.